إحساء حضرتك. Let's start now.
Okay.
Right. Bismillah ar-Rahman ar-Rahim. Welcome everyone for the first journal club in our new group. We're going to start with a very important paper called the Fundamentals of Care for Uveitis Initiative. This is basically a guideline for the use of non-corticosteroid immunomodulatory therapy, including biologics, in the treatment of uveitis. So, an international expert-led consensus initiative to develop systematic, evidence-based recommendation for the treatment of non-infectious uveitis in the era of the biologics. Methods, an international expert steering committee. From now on, we're going to refer it as ISC, comprising 9 uveitis specialists, 7 ophthalmologists, and 2 rheumatologists, identified clinical questions, and together with 6 bibliographic fellows trained in uveitis, conducted a preferred reporting items for systematic reviews and meta-analysis protocol, a systemic review of literature. This is called PRISMA. They reviewed English language studies from January 96 till June 2016. The proposed statements were circulated among 130 international uveitis experts for review. A total of 44 globally represented groups members met in late 2016 to refine these guidelines using modified Delphi technique and assigned Oxford level of evidence.
Okay,
So
Dr. Muhammad, thank
basically-
you. Thank you so much for choosing this topic. I would like to welcome all my colleagues in our first journal club. This pioneering initiative was introduced by Dr. Muhammad Abdelazim. Thank you, Dr. Muhammad, for taking care of this project. We are supposed to talk today about this very important paper. I would ask you, if you have questions, please, for the sake of time, to keep it at the end of the session. Dr. May and me will ask Dr. Muhammad during the presentation if there are anything to clarify. I would like to welcome you all, and I like to thank Dr. Muhammad after this brief introduction. Now I invite you to continue, please, introducing this very important paper. Thank you, Dr. Muhammad.
Thank you. Now this slide is showing the PRISMA protocol. PRISMA, this is one of the protocols that would help compilate literature for the purpose of systematic review or meta-analysis. So that there is no bias towards choosing papers and leaving out some which are relevant or non-relevant. So this is basically a way of trying to make the study as relevant as possible, the choice of literature as relevant as possible. And then this is the Oxford evidence level. This is basically a classification or a grading system that would evaluate the strength of studies. So obviously a grade 1 level is given to controlled randomized trials, the CRT. And if it's a systemic review of CRT, this is the highest, so it's 1A. If it's individual CRT, it's 1B. Something called all or nothing. Basically, it's a study where you notice that once the treatment has been started, there is a cut in, for instance, in the rate of death, مثلا rate, and therefore this is a strong evidence that this drug does affect mortality. Despite there is no actual study performed, this is a good evidence that this drug is effective. So grade 2 of evidence is cohort studies. A cohort study is basically a prospective group of patients with a control that you watch over time for a certain variable. And this is given a level 2 strength. If it's a systemic review of cohort studies, it's a 2A. Individual cohort is 2B. And if it's an outcome studies and ecological studies, it's 2C. And then case control studies are basically a retrospective study. It's a quick type of study in which you choose a group of patients and a group of matching controls and try to see the effect of a certain drug, for instance, taken in the past on the improvement in inflammation, for instance. So that's not a very strong evidence because it's a retrospective study. If it's a systematic review, it's a 3A. If it's an individual case report study or control study, it's a 3B. Case series, like for instance, case reports, it's a grade 4 series. Grade 4 level. And if it's an expert opinion, this is the weakest level of evidence. Methods in this study.
Dr. Muhammad, so please, can you just tell us how can this levels of evidence apply to our study?
Oh, in this study, as you can see in this slide, the international steering committee, the 9 uveitis specialists, found out some questions, some important questions that would influence our management of uveitis. And then they refined these 57 questions until they finally reached the most important 10 questions. These 10 questions were given to bibliographic fellows interested in uveitis to search the literature for evidence for this, the answer of these 10 important questions. So the bibliographic fellows have to grade the strength of the evidence they found. So if they, for instance, found an evidence in the form of a randomized clinical trial, this is a strong evidence, and they will grade it as 1, and so on. Accordingly, at the end, when they compile all the evidence, they would grade it depending on the strength of this evidence, and thereby will grade this recommendation into A or B or C accordingly. So in this study, as I just said, 6 bibliographic fellows have searched the net or they searched the literature in English language journals from 1996 till 2016, 2006, searching for relevant papers, answering the questions raised by the ISC, and graded them according to the Oxford level of evidence accordingly. Once they've done that, they rigorously discuss this evidence with the ISC and the fellows and the national faculties of 130 experts all over the world. Each in their country, they discussed all this evidence and revised it. The ISC reviewed several hundred details, comments, and incorporated key points into the final proposed evidence statement whenever possible. Finally, the ISC, the bibliographic fellows, and representatives from these national faculties met in 2016 to refine and discuss the final statements. A modified Delphi technique process was used to reach consensus on the final evidence statements associated with the agreed definitive clinical questions. So this is a diagram to simplify the way they did that, the method. The ISC, the International Steering Committee, came up with 57 important questions. They refined it until there are 10 most important questions, asked 6 bibliographic fellows interested in uveitis to search the literature using a PRISMA protocol to find literature providing evidence for these questions. And they used to grade the level of evidence, the Oxford level of evidence. They searched the English language literature from 96 to 2006, I'm sorry. And then 130 uveitis experts meeting from 27 faculties internationally, met nationally, met locally, each revising all the answers, all the evidence. And then eventually 44 representatives from this international groups met with the ISC and the fellows, used the modified Delphi technique to reach the final evidence, which is 21 evidence-based guidance statements. Is there any question up to now? Dr. Samir.
No, Dr. Mohammed, it's very clear. Please go on.
Okay.
Yes. Dr. Mohammed, what is meant by Delphi technique?
A Delphi technique is a technique where you provide some experts with some opinions and then ask them whether they agree or disagree. This is done at the first instance individually. And then they meet each other and then they start to discuss why they chose this or that. And then they do that as several cycles until there is an agreement to the choices they have taken. And then they would put this as an agreement level. Whether they all agree on this or a percentage agree on such a statement and so on. So any modification, this is called modified Delphi. So here in our case, this is a modified Delphi. They actually met physically in 2016, and then they reached the 21 evidence-based guidelines. So the results, in total, 10 questions were addressed, resulting in 21 evidence-based guidance statements covering the following topics. When to start non-corticosteroid immunomodulatory therapy, including both biologic and non-biologic agents. What data to collect before treatment. When to modify or withdraw treatment. How to select agents based on individual efficacy and safety profiles and evidence in specific uveitis conditions. Shared decision-making, communication among providers, and safety monitoring also were addressed as part of the recommendations. Here, pharmacoeconomics were not considered, were not addressed. So in conclusion, consensus guidelines were developed based on published literature, expert opinion, and practical experience to bridge the gap between clinical needs and medical evidence to support the treatment of patients with non-infectious uveitis with non-corticosteroid immunomodulatory agents. So they recognized three major focal points, focal clinical points. What is the optimal timing for treatment escalation? What are the transitional treatment to a non-corticosteroid immunomodulator? Multidisciplinary team collaboration. So the first focus area, one, the optimal timing for treatment escalation. So question one, which factors determine when any of the non-corticosteroid immunomodulatory therapy should be introduced into the management of non-corticosteroid into non-infectious uveitis. In statement one, NCSIT may be introduced for the management of NIU to control persistent or severe inflammation or to prevent ocular structure complications. Also in case of steroid intolerance, contraindications, and in the need for steroid sparing. Biologics in general are considered if conventional therapy is insufficient. Statement two, what are the indicators of severe inflammation? Is visual acuity, visual impairment, bilateral macular bilateral disease, macular optic nerve disease, macular edema, exudative detachment, retinal vasculitis, vitreous haze, or structural complication threatening vision. Also associated systemic inflammation, recurrent and chronic disease. The most important therapeutic indications for NCSIT was failure of regional corticosteroids, lack of tolerance to corticosteroids, and finally contraindication to steroids, including non-compliance, viral hepatitis, and TB.
Okay, Dr. Mohammed, I have a question for you, please, in this
Sure.
point
Sure.
before proceeding. So I agree with all of these indications, but if I have a case of bilateral mild anterior uveitis, so are you going to consider this severe disease as it is mentioned by this group?
Well, in this group, they are saying that bilateral disease can be considered as a severe disease, but it does not necessarily mean that you need to start treatment in them. So one of the indicators of a severe disease, or when you can...
So I'm allowed based on this, if I have a bilateral mild anterior uveitis, to start the conventional immunosuppressive therapy.
Exactly. I mean, you would prefer using systemic disease rather than regional treatment. Sorry, systemic treatment rather than regional treatment.
Okay.
In the case of bilateral involvement, for instance. But doesn't necessarily mean that you choose this more than that. Is that okay?
Okay, that's fine. Thank you.
This is a table summarizing all what we've just said. And this is basically the indication of NCSIT. When should we introduce NCIST or non-corticosteroid immune modulatory therapy? According to ocular and anatomy, in cases of an onset and course as defined by the Sun Working Group, acute disease that is sight-threatening, chronic persistent inflammation, exudative retinal detachment, posterior and macular involvement, binocular sight-threatening disease. As for therapeutic indications, regional failure to respond to periocular steroid injections or topical corticosteroid in GI-associated uveitis. Systemic failure, active uveitis while taking doses of 30 milligrams or more, relapse of uveitis after reduction of oral corticosteroid to 7 to 10 milligrams per day. Steroid intolerance, need for steroid sparing effect, as for instance, manic disease or morbid obesity or diabetes. Severity in adults, this is defined as visual acuity worse than 2100. Increase in vitreous haze more than 2 grades, according to Sun Group. Relapse of cystoid macular edema, disease that impacts quality of life. Severity in GIA includes prognostic factors for visual loss, such as poorer presenting visual acuity, posterior uveitis, uveitic complications of glaucoma, advanced cataract, macular edema, cyanicia, severe band keratopathy, ocular hypotony, and rubeosis iridis. So, question 2, what are the essential data and clinical information that should be collected about patients before deciding on non-corticosteroid systemic immunomodulatory therapy for NIU? Statement 1, collection of historical, lab, and clinical relevant non-ocular imaging data should take place before initiation of NCSIT. These data are used to assess baseline vital organ system functions and to test for infectious diseases. Statement 2, support for pre-treatment testing in NIU patients can be derived from experience with non-uveitic disease treated with NCSIT. Checking for family history of malignancy, although the relation is not very clear. History of malignancy or testing for TB or HIV is important before initiating biological therapy.
Okay, Dr. Mohammed, please. So in this point, I would like to ask you, what is your regimen before prescribing these medications? Are you strictly obey this, or what is your regimen?
Before I start, for instance, anti-metabolites, I would, of course, take a proper history, do proper physical examination. I leave this for the physician to do. And then I do some lab tests. Lab tests should include lab tests that would provide a baseline so that in the future I would know if there is a deterioration, for instance, in the renal functions or kidney functions. I would know that my drug is causing this, and also to exclude the presence of infection. So what I do is I ask for CBC, for instance, liver function, renal function. I do at least chest X-ray. I would do TB most of the cases, unless it's a very clear disease entity. However, I usually do TB testing just because I'm going to start immunomodulatory therapy, and that would activate latent TB. I would need to exclude that first. Hepatitis C again, and B, I also do that. So this is basically a history. I don't really take a history of malignancy, family history of malignancy, but I think if you're going to start biological therapy, I think you need to start to ask for that. There hasn't been any firm evidence to implicate non-corticosteroid immunomodulatory therapy other than biologics in the development of or increasing the risk of malignancy. But I wouldn't, if the patient, tell me that voluntarily, I would take this in consideration. But I don't think I would change the management anyway. I would keep an eye on that, but I wouldn't change my management anyway. Okay.
Okay, thank you.
Question 3, what are the clinical criteria used when deciding to adjust systemic therapy? Statement, there is a significant heterogeneity regarding the criteria used, but deterioration or lack of response in measures of visual function, anterior chamber cells, anterior chamber flare, vitreous haze, choroidoretinal lesions, retinal vascular lesions, or macular or optic nerve involvement may influence the decision to adjust therapy. Strongest criteria are visual acuity and ocular inflammation, as defined by Sun Group criteria. Question 4, this is subdivided into A and B. If non-corticosteroid immunomodulatory therapy agent is inadequately effective, what should be considered first? This is 4A. The statement is treatment non-adherence, infections, and masquerade syndrome, including malignancy or degenerative disease, must be considered in any patient with NIU before change in therapy is considered. Inability to reach drug-induced remission, as defined by Sun, as either two-step increase in the level of inflammation or an increase to the maximum grade worsening, or as a lack of two-step decrease in the level of inflammation and inability to decrease to inactive disease despite therapy, the diagnosis should be reconsidered. So for B, if the non-corticosteroid systemic immunomodulatory agent is not adequately effective or adequately tolerated, what should the next approach be? So if we know that there is good adherence and we've adequately excluded infectious causes, and we are confident this is not a masquerade syndrome, we know that the treatment we are giving is either non-effective or not sufficient, then the statement 1, the first thing that you need to do is dose escalation of the NCSIT to the maximum tolerated therapeutic dose. So there is a good evidence that increasing the dose does improve the function of the drug. Before considering introducing another medication, including another biological agent, or other approach in the management of NIU, as surgical management, for instance, or regional treatment. Statement 2, patients with NIU may be transitioned to an alternative or additional agent if the initial NCSIT is controlling the disease inadequately. Statement 3, therapy choice for patients with NIU that is refractory to NCSIT must be individualized based on multiple factors, including patient's history, underlying cause of uveitis, or other systematic comorbidities, or a combination of thereof. Now, this is a table summarizing the consideration for management of patients with inadequate response to NCSIT. The first consideration is a differential diagnosis. Sorry. Differential diagnosis that the patient might be non-adherent to the treatment, non-compliance, whether this is because of masquerade syndrome or infectious cause. The second consideration is classified into A, B, C, D, and E. A, the next step, you need to escalate the dose of the current therapy. If this doesn't work, transition to alternative non-corticosteroid immunomodulatory agent or add to the previous one. C, start using local or regional therapies. If this doesn't work, try non-medical therapy as vitrectomy or cryotherapy in some cases like partial planitis. Eventually, 2E is try biological therapy if all the above fails.
Dr.
Number
Muhammad,
3,
please.
therapy. Sorry.
Yeah, this is excellent step-ladder approach, but I would like to ask you, so if you have a bilateral systemic disease and you have bilateral involvement, so are you going to try regional treatment before biologic therapy? For example, if you have bilateral severe panuveitis, are you going to give the patient periocular steroids or intravitreal steroids bilaterally before going to biologic therapy?
No, again, this is just a guideline.
Okay.
Again, no, I wouldn't do that. If you, on the other hand, if you have a one eye unilateral disease and you're not adequately controlling it with your, for instance, steroid and methotrexate, you might like to give an orbital floor steroids before going to the next.
Yes, I agree with you too.
Yeah, but
100%,
this is just a general guideline.
Exactly, yes. But just we want to discuss to show that there are other opinions and everything is fine as long as you are managing the patient as a whole.
Exactly. Yeah, I mean, it's just you don't have to adhere to all the. You don't have to go to C from A to B. No, you can go from A to D.
Yes,
according to the condition. So, for instance, if this is not a partial planitis, there's no role of vitrectomy or cryotherapy in this case.
Yes.
So you don't have to go to D first. Okay.
Yes. Thank you.
And then 3 would clarify things. Therapies should be individualized based on history, cause of uveitis, and patient's preference. So there is a lot of heterogeneity. So not all cases of uveitis should go through this steps according what you find. Currently, limited evidence exists to support adding an additional agents. Safety and cost implications should be considered. So it's basically stating about the triple and quadruple therapy. There is no evidence that, for instance, adding cyclosporin to azathioprine and steroids would work better than using only two of them. But we still use that. We still do that because in some instance, this is the only option that we have. So question number 5, when should non-corticosteroid immunomodulatory therapy be withdrawn? And the statement here, the decision to withdraw NCSIT should be individualized based on shared decision-making with the patient that incorporates considerations such as patient's preferences, tolerance and risk resulting from the current treatment, duration of disease control, and specific cause of uveitis. So you need to consider all these points before you decide to withdraw a treatment. When they checked for the commonest causes of withdrawal of treatment, they found inadequate clinical response to be the most cited cause, the most frequently cited cause, followed by inefficacy, no effect of the drug whatsoever. And then the third cause is the presence of adverse drug reactions. Cost and desire for fertility are also considerations. So all these factors can be used to guide withdrawal decisions. We should note that any decision to withdraw systemic therapy in patients achieving drug-induced remission involves a classic risk of relapse. It should be discussed fully with the patient, as in risk to benefit ratio. So now we move to the focus area 2, transitioning treatment to non-corticosteroid systemic immunomodulatory therapy, including biologics. In this area, we're discussing in details what kind of drugs that we can use, which one is preferable, and so on. So question number 6, what evidence is available to guide the selection of non-corticosteroid immunomodulatory therapy for non-infectious uveitis, excluding biologics? So this question is divided into two parts. Question number 6 is discussing NCSIT excluding biologics. So the statement here, effective NCSIT for management of NIU include mycophenolate mofetil. Here the evidence level is 2B, which is pretty high. Tacrolimus, EL2B, cyclosporin, EL2B, azathioprine, EL2B, and methotrexate, EL2B. So in general, this is a grade B recommendation. Other agents such as chlorambucil and cyclophosphamide have been used. However, the level and amount of evidence are limited and do not meet the criteria for this report. Calcineurin inhibitors, including tacrolimus and cyclosporin and lefonamide, reached an evidence level of 2B, supporting a grade B recommendation. We should note that tacrolimus appears to be associated with less adverse effects than cyclosporin. Comparative studies of antimetabolites demonstrate moderate support for efficacy of methotrexate and mycophenolate mofetil in steroid-sparing control of NIU, grade C recommendation, with no significant difference in uveitis control among these drugs. So basically, both methotrexate and mycophenolate mofetil are equally effective and equally safe if you're going to choose one of them. The rates of side effects, lab tests, complications, and discontinuation of therapy were reported to be higher with azathioprine in comparison with both mycophenolate and methotrexate.
Okay, Dr. Mohammed, please, can I just, I
Sure.
have a question, please, for you here. So we used to collaborate with our esteemed rheumatology colleagues, and we always think that azathioprine is better in controlling inflammation. And we, based on this and on our experience, think that methotrexate and mycophenolate are more effective and have less side effects. I want to know your opinion and comment on this, please.
Well, yeah, in my experience, they are all equal. The reason why in Egypt they prefer azathioprine than mycophenolate mofetil, for instance, is because of cost reasons mainly. So the preferred drug, in my opinion, if money is no option or is no problem, is the mycophenolate mofetil. However, azathioprine is cheaper. The problem with azathioprine, the metabolism, the rate of metabolism, the enzyme responsible for this non-activating or inactivating the drug in the body, it has a different level in different people. So there is a range of fourfold range of activity. So some of the patients would have a very high degree of inactivation of the drug, and therefore the drug doesn't seem to be effective in them. And whereas others where the drug is not metabolized enough, the drug would be toxic, and they would present with things like liver toxicity or bone marrow toxicity. And abroad, they do an assay for this enzyme to, foretell what kind of what to expect, whether to start this drug or not. In Egypt, we don't have this enzyme assay, and therefore, when we start the drug, After a couple of weeks, we do liver enzymes and check CBC. And if any of them is affected, then we tend to stop the drug and not use it. But there are several papers supporting the use of azathioprine by name in cases of Behçet's disease in the long-term maintenance of anti-inflammatory effect in Behçet's disease to be more specific. Okay?
Okay, thank you.
Now, this is a table with all the drugs that we've just mentioned, with all the studies that were found in literature to support the use of these drugs, with the level of evidence for each of them. They checked three parameters: the inflammation improvement, steroid sparing, and visual acuity improvement. And as you can see, with all the antimetabolites and the calcineurin inhibitors, they're all about the same, except that azathioprine, there is no proof that it improves visual acuity. And all of them support an evidence level 2B. And therefore, they are all recommended. However, cyclophosphamide and chlorambucil support evidence level 4, and therefore, they are not recommended for the use in uveitis because of the limited experience. And there is no strong evidence that they do improve inflammation. Again, local treatment using methotrexate and sirolimus intravitreal. Again, there is no strong evidence, although intravitreal sirolimus, there are some studies supporting its use. The next question, question number 7. Which biologic should be used for the treatment of non-infectious uveitis? Sorry. Statement 1, the use of adalimumab for the treatment of NIU is supported by evidence level 1B. This is a grade A recommendation. This is actually the only study, the only drug that we use that support an evidence level 1 and a grade A recommendation, because it's the only drug in which several trials, controlled randomized trials have been performed. The study name is Visual 1 and 2. These are controlled randomized studies, and Visual 3, which is an open label study. Statement 2, the use of infliximab for treatment of NIU supported by evidence level 2B, grade B/C recommendation. Statement 4, the use of subcutaneous, the statement 3, there is no evidence to support the use of etanercept with evidence level 2B. So there is a good evidence not to use etanercept. There's a grade B recommendation not to use it. Grade 4, the use of subcutaneous secukinumab in non-anterior NIU is not supported. Evidence level 2B, so it's a grade B recommendation not to use secukinumab, which is Cosentex. However, there's a study which they tried intravenous administration of the drug with about 70% improvement in control of inflammation. Statement 5, the use of interferon alpha-2A in non-anterior NIU is supported by evidence level 2B. There is limited evidence to support the use of pegylated interferon alpha in non-anterior NIU in patients with Behçet's disease, evidence level 2B. Interferon B demonstrated efficacy in the treatment of parsplanitis in a small pilot randomized controlled trial. Randomized clinical trial, evidence level 2B, grade B recommendation.
Dr. Muhammad, I have a question for you, please. So we know you're.
I think Dr. Maha is trying to.
I admitted her twice.
I think she's having trouble. She's trying. She tried several times.
Okay. So Dr. Muhammad, we know your huge experience in the use of biologic therapy, and as we know, this paper since 2018 And I understood now from your presentation that the most commonly and the most effective two types of biologics are the adalimumab and infliximab, and this is what we are doing. So since that time, do you think that there are some other biologics that were introduced and they are becoming effective now?
To my knowledge, there is no strong evidence to include any other drugs. Other papers, they tested Simponi and Cimzia, for instance, as for treatment of non-infectious uveitis, with some success. But again, we keep these drugs as a rescue drug if the adalimumab and infliximab doesn't work. Other drugs as Cosentex, as you can see, intravenous use of the drug has shown some improvements. Other drugs as JAK inhibitors, for instance, there are no trials. They are only case reports, so you cannot use this as a guideline. Tocilizumab, there is a very small trial claiming that it is useful in the management of anterior uveitis associated with macular edema. But again, there is no strong evidence to support that.
Okay.
Till that point, there is no strong evidence to support other than adalimumab and infliximab.
دكتور محمد معلش تسمح لي from your experience using the biosimilars, and I know we have in Egypt now using biosimilars especially for adalimumab. Do you think they are really that effective?
I believe so. There are several type of biologics. Hiermose, for instance, I think is equally effective. Maybe the only problem with it, it's more burning sensation with subcutaneous use because it's acidic. This has been corrected in the Humira. They used a buffered type of chemical to decrease this stinging sensation. Amgevita, to my mind, it was not effective at all. Mind you, in Egypt, we're going into a crisis with the Humira and the Hiermose, and we are shifting to a new type. They're introducing a new type. I'm not sure the name of the type, but I think there will be a shortage in both Humira and Hiermose in this coming period.
Do you think the difference in the results of these drugs in Egypt and other countries may be related to our genetic map, maybe, or just that we use many shifts between drugs according to availability? We can say, can we judge it's really non-effective with our mode of choice, or we just choose the available?
Well, if you don't have a study, you cannot draw any conclusion, because there are 1,000 causes why this patient might have not responded to this or that. It might be this disease or her disease is too aggressive, for instance, and it wouldn't have been controlled by Humira. However, there are studies that support that both are the same. And the FDA approved the biosimilars in the United States, and the European Association has supported the introduction of biosimilars in Europe. Actually, they are encouraging people to change from Humira to Hiermose, for instance, because this is less expensive. So even Europe, which is much more rich than Egypt, they are looking for the economical factors, and we are even more in need of this. And there are several papers to support that they are equally effective. If you have an experience that they are not as effective, it could be related to the storage. And I think the problem with the storage of Amgevita was the cause of the disappointment. I think the amount that came in Egypt, I think they were wrongly, stored or something like that.
Okay, thank you. Okay.
So the next slide is a map including all the biologics available. And as we've just said, the only drugs certified for the treatment of uveitis are the anti-TNF, namely infliximab and adalimumab. Golimumab and cetirizumab can be used, but again, there is no strong evidence. It's a grade 4 level of evidence. Etanercept, there has been evidence of being non-effective. Actually, paradoxically, it can cause uveitis by itself. Several other biological agents are not available in Egypt, as anti-leukin 1, for instance. Tocilizumab or anti-leukin 6, it's been effectively used in giant cell arthritis, for instance. But there is only a couple of trials, small trials, using it in anterior uveitis and intermediate uveitis with macular edema, with, again, a low level of evidence. The rest, as you know, the rituximab or anti-CD20, again, the role in uveitis is limited. However, it has been tried in anterior uveitis, posterior uveitis, particularly retinal vasculitis, with some success with the C grade of recommendation. Others as interference, they are being used particularly in Behçet's disease. Question 8. How do you assess patient safety while on non-corticosteroid immunomodulatory therapy? Statement: support for safety monitoring while administering treatment derives from experience with uveitis and non-uveitic diseases that are treated with NCSIT. Basically, which means that we derive most of our knowledge from the rheumatology guys and the other immunological disease. An interdisciplinary panel of 12 uveitis specialists and rheumatologists convened in the year 2000 to outline best practice and guidelines. Again, this is not an evidence, but these are experts who came together to put a plan or a map to when to use the corticosteroids, for instance, when to withdraw it with the best tapering schedules, and when to introduce non-corticosteroid immunomodulatory therapy. And they stated each type of drug with the appropriate dosing and when to stop and what the side effects and how to monitor it. I'm stating the name of the paper in pale blue in the lower part of the page, and you can find it in you can find a link in the chat box if you are interested to look at this paper. So focus area 3, collaboration across the multidisciplinary team. So question number 9, how would you discuss the therapeutic options, pros and cons, and make a shared decision with the patient? Again, a shared decision with the patient is a big thing in the West. Shared decision-making is an appropriate strategy in caring for patients with NIU, but there are limited data to guide this interaction. Discussions regarding the choice of therapy should be tailored to fit the needs and expectations of individual patients and their healthcare professionals. Best-worst scaling have been used as an estimate for patients' preference in the treatment of uveitis in patient survey from multi-centered uveitis steroid treatment trial follow-up study. The best-worst scaling is a method of studying what is the preference of a patient. Basically introduce to the patient a best scenario and the worst scenario for each drug, and he would choose what he would prefer. If, for instance, in this study, in the MUST study, they found out that the patient would rather anticipate having diabetes or hypertension than having cataract or glaucoma secondary to intraocular steroid injection and having to do an ocular surgery, and that he might lose or she might lose the driving license, for instance. So basically, they are recommending that we use such a method when we are choosing our treatment with the patient. Ask the patient whether they like to have an injection once a week, for instance, like in methotrexate, or rather they take an oral therapy, and whether they would rather take the risk, or if they have enough money to use the mycophenolate mofetil, for instance, and so on. Question number 10, I'm sorry. How do we ensure effective communication between internists or rheumatologists and ophthalmologists to optimize safe prescribing and monitoring of systemic therapy? Statement: patients with uveitis may benefit from the input of more than one medical specialty. Communication among health care professionals foster optimal diagnosis and therapy. The optimal method to enable this communication require further investigation. Evidence level 4, recommendation grade C. Multiple cross-sectional survey of physicians have demonstrated that the lack of coordination between primary care physicians and specialists negatively impact patients' care, and this further impacts the patient-physician relationship by reducing patients' confidence in their care. Although it is difficult to quantify its benefit, the authors believe that an interdisciplinary clinic, for example, one that combines rheumatologists and ophthalmologists at the same physical location, is an effective approach to optimize communication among specialists. Obstacles to this communication paradigm include challenge to use time effectively for all practitioners and issues regarding the division of compensation for the care provided. Dr. May, I think you have an experience in this point.
Yes, we do in Qasr Al-Aini. We upgraded our clinic from just uveitis only with ophthalmologists, and we now are hosting our dear rheumatologists physically in our clinic each week. They are present, and this under sponsor طبعا support بتاع Dr. Maha Yusuf. Although it was maybe it was difficult at the start to make the timing of two different departments with settings that in our ophthalmology clinic to fit internist or rheumatologist, but with some passion and interest from both departments, we could host them. The patients now are seen in the first visit with, if he has systemic disease, with the ophthalmologist and the rheumatologist at the same day, with a clear protocol of what he is going to do, what investigations and laboratory of investigations, either labs or imaging, he will do in the same prescription. He doesn't have to go many times to many physicians and go to the lab many times. And then when he come back, usually he have another date of mutual clinics. So we can take the decision easily and rapidly, especially in busy hospitals as university hospitals like Qasr Al-Aini or Kafr Sheikh or Alexandria. I think this saves a lot of money and time and health and vision of the patients. So it was a great experience. I would recommend everyone to share, even in their private practice.
Well, this is a very positive experience that you've just mentioned. However, I try to do that, and in private sector, it's a little bit more difficult because you have a problem with the time, as has been mentioned in this paper, and you have a problem with the money. How are you going to split the money? These are real problems. But as you just said, it's very inconvenient for the patient to go to me first and then go to the rheumatologist, and then I have to phone the rheumatologist, they have to phone me. So there is a difficult communication, and it would be made much easier if we share the same physical place. So in summary, multidisciplinary collaboration comes in many forms, with the benefit from such interactions documented in peer-review literature. Their specific application to interdisciplinary relation among ophthalmologists, rheumatologists, and internists for management of uveitis need further and more specific study in the coming years. So the discussion The goal of the Focus initiative was to support optimal management of NIU with the aim of improving patient outcomes. This program included an academically rigorously processed or rigorous process supported by a large number of uveitis specialists worldwide, including both rheumatologists and ophthalmologists who collaborate in the care of patients with NIU, and represents a broad range of clinical opinion from diverse geographic regions and variety of clinical practice. We further recognize that regional differences such as the prevalence of TB should influence clinical advice. Although we consider recurrence an indicator of severity, we acknowledge that the nature of uveitis disease, associated systemic disease, and frequency of recurrence are all important in any decision to initiate NCSIT. A limitation of program with greater representation from Western European countries and United States compared with Eastern Europe and Asia. As you have noticed here, there is no mention of Africa altogether. Furthermore, some evidence had to be drawn from literature outside of uveitis treatment or drawn from experts' opinion, and subsequent consensus around those opinions was provided when experts involved in the initiative. These are the weak points in this study, in that some of the evidence is drawn not from ophthalmology-related or uveitis-related studies, but rather than arthritis and other immunological disease. And some evidence are drawn from experts' opinion, which represent the weakest level of evidence. There was only a brief analysis of local, surgical, or other management approach. And again, this is another weakness in the study. The management, the surgical management was not discussed except very briefly. Local management was almost not discussed at all. Finally, it should be acknowledged that clinical practice varies depending on local factors such as availability of medications or demographics of patients. Because this was intended as a global initiative, local adaptation and application should be considered. The initiative has identified clearly the opportunities to collaborate with colleagues and to identify optimal methods of communications and co-management of patients. We've finished and we're now open for questions.
Okay. Thank you, Dr. Mohammed, for this very nice and attractive presentation. Really, you touched a very important paper, and I think this is a milestone in ophthalmology. And I would like to thank all our colleagues who attended. I just want to tell that this is a relatively different platform than ordinary presentations, and it is a good start. And I recommend that our colleagues read the papers before Dr. May, Dr. Mohammed, and I will announce the topics of the journal clubs. And I think it will be good to read the paper thoroughly before discussion. And this is the main aim of this platform of education. Thank you, Dr. Mohammed, again. And Dr. May, we can now open the discussion from our colleagues if they have questions for Dr. Mohammed.
Okay, everyone who wants to send their questions, please. We have already one question from Dr. Ale. He is asking about patients post-viral hepatitis treatment. In the presentation, حضرتك told us that post-viral hepatitis patients are contraindicated to take steroids, so we can give them immunomodulatory therapies was an indication. I guess this is the conflict. If we can't give steroids, but we can give immunomodulatory, or how you manage post-viral hepatitis patients.
Very good made points. Well, actually, if there is hepatitis, I would rather not use neither steroids or non-corticosteroid immunomodulatory therapy. I would rather use local treatment. I would rather use orbital fluor, for instance, or intravitreal. However, there are some conditions where you're more worried about steroids than non-corticosteroid immunomodulatory therapy. Rather than the intolerance, for instance, to steroids steroid-induced mania or depression, you can avoid it by just giving NCSIT and avoid steroids altogether. But in infectious uveitis, he's completely right to take this note. I wouldn't use either neither steroid nor NCSIT. Of course, non-biological as well.
Some of our patient, Dr. Muhammad, thank you for your nice presentation and your declaration about the immunosuppressive treatment is our medication against the uveitis, which destroyed the eye and the vision of our patient. For the viral hepatitis, some of these cases develop immune reaction. It will continue for months, like post-interferon treatment, post-viral hepatitis. This is a point that the patient needs to have treatment. He will not tolerate that he have regional injection of steroid for many frequent injection. For our rule, a routine subtenual injection or subconjunctival injection only about 3 to 4 times per eye. After that, to reduce fibrosis and ptosis and complication and dilemma with the patients. So this is the point.
I'm sorry to interrupt you, but the sound is not very clear.
Some of our patients, Dr. Muhammad, develop uveitis after having hepatitis B or C. Another type of patient develop post-interferon treatment.
Post-interferon, sorry?
Post-interferon treatment as a treatment for viral hepatitis. The 3 months dose or the 6 months dose. And I have 2 patients like that. They develop Harada light and they need long time treatment. Maybe 2 years I treat one of them and finally it's okay. But when I asked about the question about the immunosuppressive treatment, they have any recommendation if the liver condition is good after viral hepatitis treatment, which medication we can use safely in these patients?
Well, I'm sorry. Most of your words I didn't hear, but I think what you mean is that drug-induced uveitis. I think you mean that interferon in hepatitis can induce uveitis. This is your question?
No, Dr. What I understood from Dr. Ala's question, also the patients that recovered from viral hepatitis, how would you manage them? Am I right, Dr. Ala?
Yes. This is one of the patients.
Yes.
He recovered from the viral hepatitis after treatment, but he developed immunoproblem and developed Harada light. What's the best treatment for this patient with immunosuppressive drugs?
Can't hear.
So I think Dr. Ala, from just my experience, I didn't see so much patients from this. But for example, I have a couple of cases of HIV, and there is a problem also in giving them these medications. I usually consult the internists and the people who are taking care of these patients before selecting any medication, before prescribing any type of medication to them. This is my experience. Dr. Muhammad, I think you got the question now. Dr. Muhammad, can you hear me?
I can hear you, but what's the question?
I think Dr. Ala is asking if the patient recovered from a viral hepatitis, for example. So are you going, what type of medication you are going to give him? Are you still able to give him immunosuppressive therapy, biologics, and this stuff?
Right. So basically the question is if the virus is inactive because it's been treated, whether you can still give non-corticosteroid immunomodulatory therapy or steroids. This is the question, right?
Yes.
Yes.
Well, yes, in collaboration with the rheumatologist. Again, if there is a latent disease, as TB, for instance, you need to treat latent TB. If there is hepatitis, there is only a positive serology, but negative PCR. I think you can go on and give the treatment, but cautiously.
Okay. I think this will be according to recommendation of the liver specialist. He will give us the liver will tolerate medication.
Exactly.
Okay.
Exactly.
Thank you.
Exactly.
Sorry, the sound is not very good. So,
Yeah. So do we have any other questions from any of our colleagues or any comments?
Okay, I have a comment about the globality of the researcher. How many people from Asia and Turkish and the Gulf area, because this area are full of TICIT and VH.
the quality of the sound is not very good, Dr. Ali. I think you're talking from a wireless device, I think.
هو دكتور علاء لو كتبوا في الشات هنبقى قادرين نقراه
نكتبه
هيبقى
from
أسهل من الصوت عشان مش واضح خالص.
Japan.
So meanwhile, while Dr. Ala is typing, Dr. Muhammad, they mentioned in the paper that this is not an algorithm. This is a recommendation. So can you elaborate more, please, on this?
One of the weak points in the paper is that some of the gaps where there is no solid trials or solid studies, the information is drawn from experts' opinion, and then they take a consensus on this. So this is an agreement between experts rather than evidence to support this or that.
Yes.
So one should always be careful. And again, everything is provided, whether this is an evidence-based opinion or there is no strong evidence and so on. This is what's good about the paper.
Yes, exactly. I agree with you. Dr. Mai, Dr. Ala has finished his question.
There are
his first question is how many papers from Japan Gulf area in this papers area has huge number of PSHATs and VKH.
Concerning this study, they have searched all English language journals. Again, Japan or Turkey would very often, publish in this peer view papers or journals, and therefore would be included. I'm not sure what individual papers are, but many of the Behçet's disease studies and VKH studies would be originating from these areas because they're very uncommon in the West.
Muhammad.
Okay, thank you, Dr. Ala. Do you have any other question, Dr. Ala?
Thank you, Dr. Samir. Thank you, Dr. Muhammad. Thank you, Dr. Amay, for your nice organization.
There are several papers very interesting to read, and they are very important in our clinical practice, like the MUST trial, for instance. This trial basically is testing whether local injection of long-acting steroid is better or oral treatment is better. And initially, it found that local injections are better, but with longer follow-up, it found out that oral treatment gives better control of uveitis and better patient satisfaction. So this one of the studies. Other studies are the visual 1 and 2 and 3. The importance of these studies are the design. They're the typical randomized clinical trials with a very strong evidence. Again, there are several papers that are present that defines the management of uveitis, and I think are good candidates for the next journal club, especially the Sun studies with classification of uveitis.
This is very important, Dr. Muhammad, yes.
So I encourage all our colleagues to adopt any of these papers, and they are all welcome to present and whenever they like. first tell us what is the paper, and we will read it first and then come and discuss it together.
Okay. Thank you, Dr. Muhammad. Dr. May, do you have any other questions?
No, Dr. Samir, المسج كانت very clear الحقيقة.
Okay. So I think by this we can conclude our first session. I would like really to thank Dr. Muhammad Abdelazim for the nice presentation and very attractive topic. Thank you, Dr. Muhammad.
Thank you.
I would like to thank also Dr. May for her great efforts in the organization and making things running very smooth. Thank you, Dr. May.
Thank you, Dr. Samir.
Inshallah, the next meeting we will discuss ocular sarcoidosis, Dr. Muhammad, right?
Yes, inshallah.
Okay. Thank you so much, and see you all again. Thank you.
Thank you. Thank you.
We have the paper. I sent it in the chat if anyone want to download it, and would be sent again with the announcement of the next journal club.
Okay, thank you. Thank you so much. And thank you for all the attendance.
Thank you, Dr. Samir, for all your effort in making this work, and I hope we are waiting for your paper, inshallah, and then we are waiting for the presentations in our group. Again, everyone is invited to present anything that would start the proper discussion, and then we are announcing also we're going to start our audio podcast, with it's like a mini reviews of each branch of uveitis, with exciting or with important topics, and I hope this would be useful for everyone, including ourselves.
Hopefully so. Thank you.
Thank you very much.
Goodbye.
See you again. Bye bye.